and how many times do we see in our practice where somebody comes in and they don't feel right, they feel off? And we actually see this on the aesthetic side, whether they're coming in for wellness or aesthetics, something has changed. I look old or I feel bad, and we look at their symptoms and they are already on an SSRI. They have been admitted into psychotherapy for depression, anxiety, insomnia, fatigue. They have been added gabapentin onto their list. They are on multiple medications, and coming down, looking at their blood work, narrowing it all down, we start them on a basic level of hormonal therapy. And within months, they are feeling completely different. We are able to help them wean off of their SSRIs, transition them over to their other practitioners, and they are coming off all of this other therapy with just the one intervention of hormones.
Right.
Cholesterol medications have improved. We've gotten them off of statins. The list really kind of goes back to what happens when women present with that initial perimenopausal, menopausal presentation. High cholesterol, weight gain, fatigue, insomnia, depression, anxiety, heart palpitations. The list.
And weight gain is a big one that we see, and the redistribution of fat that happens in women who are perimenopausal and postmenopausal is really interesting. So some of them don't necessarily gain weight, but they gain visceral fat, and we know that's very inflammatory. And all postmenopausal women gain visceral fat, which is really unfortunate. We didn't always get the good end of the stick, but visceral fat is very inflammatory. It's very bad for us. And it definitely increases in perimenopause and menopausal times for women. Hormone replacement improves that. Visceral fat is not something that you can really easily lose with just dietary changes. So other interventions have to be taken. But I want to talk about perimenopause a little bit, because one thing that we use here a lot that not all practitioners who do hormone replacement use is testosterone replacement. Testosterone is actually the most abundant hormone that we produce. I think it's about 3 times the amount of estrogen that we produce over our time, and it does decrease long before menopause. A lot of women will start getting decreasing numbers in their 30s. Used to not be on board with hormone disruptors and stuff in our normal day activity, but there really are a lot, and we're seeing lower levels of hormones and hormones decreasing faster, I think, than they have in the past. And gosh, I remember when mine went down, I was in car line with my kids, going to pick my kids up, and I don't nap. Even in med school, 36-hour shift, I could not sleep during the day. It was like not in my DNA. I'm in car line for my kids. Literally, I'm falling asleep, and I'm thinking, what is wrong with me? So I go, and my husband's an OBGYN, and we had just kind of started really getting into education on testosterone, and I said, I don't think I'm in menopause, but something's really not right with me. And we checked my testosterone level, and it was 0. I had none. And I thought, okay, well, maybe that's it. So we started me on some testosterone, and I got better. My fatigue definitely went away, and my normal no nap scenario came back. So, from an anecdotal, personal side, testosterone was very beneficial for me. There are a lot of people who don't think that women necessarily need it, but we do relieve a lot of the perimenopausal symptoms with testosterone, and we use it in different forms. We do creams, we do vaginal suppositories. I think I have one lady on injectable, which is really hard for women because the dose is so small. And then we do use pellet therapy. And there are no FDA approved testosterone therapies for women in the United States. There are in other countries, but we don't have them here. So everything we use for testosterone is considered off-label. But testosterone is really important for us, again, for brain health, for heart health, for bone health, for actually maintaining your bone strength and your muscle strength. Testosterone is really important. And I know there's some people out there who don't really believe in pellet therapy, and that's fine. We started with it because the company that we use was actually educating on women's health and hormone replacement. And I really appreciated that because there were not a lot of people that do. And they were big proponents of women's health. So I really felt like Pt.2 was doing a huge service for women's health. Even though you may not agree with where their initial teachings were on where levels should be, that's really been adjusted, over time as you use replacement on things. I think, you get better at what's real, where should a level really fall. And I think even in our practice, we've come down on where women's levels should be, because you really don't want to make a woman a man. That's not what they're, what they want, but you want to relieve those symptoms and you want to give them the protections that testosterone does. And honestly, a lot of women come in and complain about the lack of libido. They don't want to have sex with their partners anymore. And not across the board, but for a majority of women, getting them back on some testosterone can help that.
Absolutely. Going back to perimenopause, let's just talk about that. So that typically starts about 10 years before actual menopause. And that number, I feel like, has gotten earlier and earlier over the last couple years in our practice alone, and then not accounting for the Hispanic population, the African American population, where we see it earlier than in the Caucasian population. And just being mindful to those early onset symptoms, and they can be very vague symptoms. It actually, we see it in the aesthetic world all the time. It starts as dry skin.
Yep.
It starts as glycation. It starts as things that, dermatitis is, things that we typically wouldn't associate with a perimenopause or menopausal presentation. One thing I feel like we do very well here in our practice is when somebody comes in aesthetically or for the wellness side, we are really good about getting a really in-depth history and figuring out what is the cause of the reason that you're coming in. A lot of education goes into our visits. We spend a lot of time digging down deep into what is going on and educating. And like Dr. O'Neill has explained, it's not about always alleviating the symptoms. That is the first part of the puzzle, but honestly, we're looking at your longevity. We want you to live longer. We want you to live healthier. We don't want you to be slumped over. We want you to be strong, build muscle. And we see it anecdotally, we see it in the research. You cannot do these things without hormone replacement as you go through this transition time.
Agreed. And we don't just see women, we do actually see a lot of men as well for all things that we do here, for the hormone replacement, for wellness visits, for aesthetics. And testosterone is really important for men as well. And the fear that it causes prostate cancer, I hope, has been debunked in men's and physicians' minds as well, because it doesn't. That study, again, was a very flawed study. We do know that men need testosterone, and they need it at certain levels. So sometimes a man will come in and see us, and they're like, yeah, I feel okay, but I don't feel great. Maybe I could feel better. And we get their level back, and their level is, 290, which is really low. The numbers for men, I think it's below 450, they start to be at risk for metabolic disease. Below 350, all-cause mortality increases. Below 250 is where you start to see buildup of plaque in the arteries and stuff. So I guess the good thing about men is we do actually have studies that show us where their levels really need to be. We don't have that for women. It's unfortunate. I hope that those studies are being done out there so that we, in general, have a better idea about where we should really keep women's numbers. There are some studies on estrogen levels in terms of where they kind of need to be to actually get to the parts of the brain where it matters, like the hippocampus. But for men, we do have numbers on testosterone, and we know they need to be above 500, or all of those things that I just talked about. Their risks increase. Again, men are a lot easier to replace. It's a bigger number. Injectables are easy. I know when I use injectables, I like to have them do it twice a day sub-Q instead of IM, which is intramuscular, because I feel like you get a more steady state. I don't like the big highs and lows that you get from an IM injection. So if men are going to do injectable, I like twice a week sub-Q. Get really good numbers. Men feel really good on that. I'm not a huge fan of creams in men. And just talking about creams in general, if you see a practitioner who uses creams and they're getting compounded creams, we use a lot of compounding here. We have a very good pharmacy who does third-party testing. Everything is done by the book there. So if you're seeing a practitioner who uses compounders, just make sure that they're using one that follows all of the guidelines. We do, so I don't really have any qualms about using compounded testosterone creams over a prescription one. I actually find that it's often less expensive for women because I can combine both their estradiol and their testosterone into one cream, and it's, I don't know, $25-$40 a month. And a lot of times if you're trying to do a patch, it depending on your insurance, may or may not be covered. If it is, awesome. And androgel, again, may or may not be covered. If it's not covered, it's super expensive. If it is covered, it's usually not at 100%. So, if you've got somebody who's a good compounder, a lot of times that's a better way to go. Men should run somewhere 700, 800, 900, 1,000. That's really hard to achieve with a cream. So injectable or a pellet in men get very good sustained results. We monitor blood work, and that's the other thing. No matter who you're seeing for hormone replacement, they need to be monitoring your blood work. They need to be checking your levels. They need to be following you up on a regular basis so that make sure your symptoms are in check. Make sure that your levels aren't too high, because again, if you're too high, there are things that can happen. So just making sure that you're seeing somebody who's not over medicating you. Again, men can get osteoporosis. It's not just women who can get osteoporosis. So men who age and never replace their testosterone oftentimes will have osteoporosis as they get older, and their size will shrink, their muscle mass will decrease, and sarcopenia, or the loss of muscle as we age, is a real problem for both men and women. And weightlifting, of course, is super important, but estrogen and testosterone for women's muscles, really important. I always say estrogen keeps your muscles strong, testosterone keeps your muscles around. In men, testosterone is, of course, super important for them for muscle strength, protein synthesis within the muscle. They age much better if their testosterone levels are kept in the right place, and they feel better.
I used to, I guess I always kind of laugh about this in the clinic, is typically we get our women in and we get them feeling better, and then sure enough their husband comes along, and their husband comes in and they sit down and they say, I feel fine, I have no problems having sex, she made me come, I don't know why I'm here. So we check their labs, and of course we get back their level, usually less than 300. We go through our initial education, we talk about risk, all the things, and they usually go ahead and start the therapy, whether it's the pellet or the shots. And within about 4 weeks, they're getting their follow-up labs. We're getting them back into the clinic, and it's like night and day. Like, I can almost say about 95% of men, and I think Larissa can too, they literally will look at us and say, man, I did not know that I felt this bad. I feel amazing. And I had one guy describe it. He said, it's almost like somebody took Windex and sprayed it on my glasses and wiped it off, and I could see clear, crisper. I could mentate more acutely. We always talk about hormones don't take away the irritating people or your irritating circumstances or your stress, but how you react in those situations, how you're able to work through those situations is definitely improved.
I think that the challenge sometimes with women is they come in and one of their biggest complaints is, I don't want to have sex anymore. And so you check their levels, you get them on their hormones, and maybe they don't feel better, right? Like, they don't notice that as the improvement. And so having the conversation of these hormones are they're not just to improve your libido. They're maybe they don't give you as much energy as you want. And you really have to educate on, okay, we're really trying to improve your health span. We're trying to improve your risks of heart disease. We're trying to decrease your risk of Alzheimer's. We're trying to decrease your risk of hypertension, visceral fat gain, elevated cholesterol levels as you age. And so really understanding and helping women and men understand that the lack of hormones has a huge effect on your overall health for me is what's most important.